Hi, my name is Francisca Chou, and I'm a third-year medical student working with Dr. Guohua Li and Stanford Chihuri on a study looking at factors related to distress experienced by physicians during their first COVID-19 triage decision. So our study is an analysis of the first sample of data drawn from the COVID-19 Healthcare Personnel Study, or CHPS in New York State. And this really is a longitudinal study aimed at understanding and mitigating the adverse impact of the COVID-19 pandemic on healthcare workers in New York. And this study was designed and implemented by a research collaborative comprising faculty investigators at Columbia University, New York University, City University of New York, and Hunter College. For our study, we asked if just-in-time training and COVID-19 guidelines, clinical guidelines, were associated with decreased distress experienced by physicians during their first COVID-19 triage decision. And just to provide some background on our research question, the COVID-19 pandemic has really brought on waves of uncertainty, both within clinical settings and for the general public. And anxiety and distress among clinicians taking care of patients with COVID-19 is really a topic of growing concern. In fact, sources of anxiety amongst clinicians with respect to patient care during this time include concerns about a lack of access to up-to-date information, lack of personal protective equipment, and the ability to provide competent care in new environments. So in an effort to reduce the distress experienced by clinicians, experts really recommend establishing ample guidelines and policies pertaining to the distribution of resources, such as hospital beds, medications, ventilators, etc. So we chose to evaluate just-in-time training and clinical guidelines because both are tools that clinicians use in decision-making for patient management. Just-in-time training, as you may know, is a method of out-of-classroom foundational instruction, at times in the form of a video or a simulation, and it's really aimed at bolstering clinical learning. And prior research has reported that just-in-time training is an effective tool in helping physicians in training improve their confidence and comfort level with various procedures. And clinical guidelines have long been used by clinicians as a framework, often informed by evidence-based medicine for delivering patient care and developing standards of care. So we specifically aim to determine whether physicians who receive just-in-time training and COVID-19 related clinical guidelines reported significantly lower levels of distress during their first COVID-19 triage decision compared to physicians who did not receive just-in-time training and COVID-19 clinical guidelines. Our study used the first cluster of survey responses collected from the CHPS. This was collected between April 28th and May 1st of this year. And just for some context, as of May 1st, there was a total of 308,000 confirmed novel corona cases in New York State. The survey that was sent out was confidential, and it was sent out to all licensed physicians, nurse practitioners, and physician assistants in New York State by the State Health Commissioner's Office. The survey consists of 40 questions which pertain to demographics, professional practice, living environment, interactions with COVID-19 patients, attitudes towards the COVID-19 response, personal mental health impacts of the pandemic, guideline usage, and just-in-time training usage. Our exposures were separately defined as having received just-in-time training and having received clinical guidelines on how to manage patients with COVID-19. So our outcome of primary interest was distress experienced by physicians during their first instance of COVID-19 triage decision-making. And the survey assessed distress scores using an ordinal scale from 1 to 10, with 1 representing not at all distressed and 10 representing extremely distressed. We also assessed the prevalence of severe distress, which was defined as a self-reported distress score of 9 or 10. We only included physician respondents involved in COVID-19 patient care, and in the survey, we looked at demographic data, which included age, gender, primary specialty, years of practice, redeployment status, meaning if the clinician needed to practice in a new setting due to the pandemic, a self-report of having sufficient skills and expertise, and a self-report of if the first COVID-19 triage decision aligned with the respondents' core values. So in total, we had 164 completed physician survey responses. And they had completed sections on the survey on just-in-time training, clinical guideline use, and distress during their first COVID-19 triage decision. Most were 40 to 59 years old, specializing in internal medicine, and most were 1 to 10 years post-residency, not redeployed. Most reported that they did have sufficient skills and expertise, and also most indicated that their first COVID-19 triage decision was in fact consistent with their core values. We found that younger age and less post-residency years of practice, as well as redeployment, really predicted having received just-in-time training, with redeployment as the most significant predictor of having received just-in-time training. And also, we found that having sufficient skills and expertise was the most significant predictor of having received COVID-19 related clinical guidelines. So here I wanted to highlight briefly what I just mentioned. Young age and less post-training years of practice, as well as COVID-related redeployment, were the most significant predictors of having received just-in-time training. And a report of having sufficient skills and expertise was the most significant predictor of having received clinical guidelines. We ultimately found that having received just-in-time training and COVID-19 clinical guidelines was not significantly associated with lower mean distress scores. So we see here there was no significant difference between the mean distress score of those who did and did not receive just-in-time training, and similarly, there was no significant difference between the mean distress score of those who did and did not receive clinical guidelines, COVID-19 related clinical guidelines. Additionally, we found that having received just-in-time training in COVID-19 clinical guidelines was not significantly associated with the prevalence of feeling severely distressed. So as we see here, there was no significant difference between the prevalence of severe distress, specifically less severe distress, in those who did receive just-in-time training, and there was no significant difference between those who did and did not receive clinical guidelines in terms of their experience of severe distress. Overall, our mean distress score in our cohort of 164 physician responses was 6.1 plus or minus 2.7. And this is, again, a reminder, a 1 to 10 score that was self-reported. And the significant predictors of higher mean distress score included female gender, less post-residency years of practice, a self-report of not having sufficient skills and expertise during the pandemic, and a self-report that the first COVID-19 related decision was inconsistent with the physician's core values. Notably, we found that physicians who reported that their first COVID-19 triage decision did align with their core values, they had significantly lower mean distress scores compared to physicians who reported that the decision did not align with their core values. And in terms of severe distress, 20.7% of respondents reported experiencing severe distress during their first COVID-19 triage decision. And the most significant predictor of severe distress was insufficient skills and expertise, inconsistencies between the first COVID-19 triage decision and physicians' core values. And we found that physicians who reported their first COVID-19 triage decision did not align with their core values. They had a significantly higher prevalence of severe distress compared to physicians who reported that the decision did align with their core values. So here we see that having sufficient skills and expertise, as well as a consistency between the first COVID-19 triage decision and core values, was significantly associated with lower mean distress scores. Here with the p-value 0.002, and here with the p-value of less than 0.0001. And here we're showing that those who did report having sufficient skills and expertise did experience a significantly lower mean distress score, and then those who said that their first COVID-19 triage decision was consistent with their core values also experienced significantly lower mean distress score. Additionally, having sufficient skills and expertise, as well as an inconsistency between the first COVID-19 decision-making and core values, was significantly associated with a higher prevalence of severe distress. So here we see that for those who reported not having sufficient skills and expertise as well as those who reported that there was an inconsistency between their first decision-making and their core values. They had significantly higher prevalence of feeling severely distressed during that first COVID-19 triage decision. So here we show the association of self-reported distress and feeling severely distressed with the most significant physician characteristics previously mentioned. And this table is specifically adjusted for age, gender, post-training years of practice, and having sufficient skills and expertise. For physicians who reported that their first COVID-19 triage decision did not align with their core values, they had a mean distress score 2.3 points higher overall than that of physicians who indicated that their first COVID-19 triage decision did align with their core values. And the odds of severe distress among physicians who reported no alignment between the first triage decision and their core values was 6.33 times higher than those who reported an alignment with their core values. And in terms of severe distress, physicians who reported, in terms of sufficient skills and expertise, physicians who reported insufficient skills and expertise had a mean distress score 1.23 points higher overall than that of physicians reporting sufficient skills. And the odds of severe distress among physicians who reported having insufficient skills and expertise was 2.99 times higher than those who reported having sufficient skills. And so here we see that in terms of just-in-time training and having received clinical guidelines, there was no significant difference between the groups that did and did not receive these resources. In general, we found physicians who reported having insufficient skills and expertise, as well as an inconsistency between their first COVID-19 triage decision and their core values, reported higher distress scores compared to physicians who reported having sufficient skills and expertise and a consistency between their first COVID-19 triage decision and their core values. So here we see that for those who had their first COVID-19 triage decision inconsistent with their core values and reported insufficient skills and expertise, they had the highest rates of highest distress scores. And those who reported sufficient skills as well as a consistency between the decision and their core values had the lowest distress scores. Overall, physicians who reported having insufficient skills and expertise, as well as an inconsistency between their first COVID-19 triage decision and their core values, had a higher prevalence of experiencing severe distress compared to physicians who reported sufficient skills and a consistency between that first COVID-19 triage decision and their core values. So here we see that for those who reported a consistency between their decision and their core values, as well as sufficient skills and expertise, they had a much lower prevalence of severe distress than those who reported insufficient skills and expertise and inconsistency between their decision and their core values in really a stepwise manner. So in terms of the limitations of our study, we did work with a small sample size of 164 survey responses. We must also consider that because we were using survey responses, we have to consider response biases that may lead to falsely answered questions on the CHPS survey. Additionally, the distress levels that physicians were experiencing and reporting on our survey may not have stayed consistent throughout the pandemic. As a reminder, our sample of data was collected right after the peak of COVID-19 cases in New York, and distress may have reduced gradually as the pandemic unfolded. It was also unclear from the survey when the respondents did receive just-in-time training and the clinical guidelines, whether this was before making their first COVID-19 triage decision or after. This was not exactly specified on the survey, but is important to note. And the survey did not characterize or define the term core values specifically. So this could be interpreted widely, including ethical, religious, and political considerations. And although the survey did specify having respondents report on their distress during their first COVID-19 triage decision, the word triage used in this context could have carried various meanings, including patient triage within the emergency department, patient triage to the floor, and even from the floor to the ICU. In conclusion, we found that receiving just-in-time training in COVID-19 related clinical guidelines was not significantly associated with lower levels of distress experienced by physicians during their first COVID-19 triage decision-making instance. There was, however, a strong association between making COVID-19 triage-related decisions consistent with one's core values and lower mean distress scores. We believe that the results of our study support a need for more measures to ensure that healthcare workers have access to mental health resources, both to help address and alleviate the moral distresses that may arise from a discordance between their clinical decision-making and their core values. And thank you so much for everyone's time and the opportunity to present at this symposium.
All right, great. Francisca, thanks very much. I have a couple of interesting things that interest me. I'm curious. I wonder, has the population of the physicians that are actually making these decisions changed lately? I knew in the early days, many physicians were being recruited from outside, the area, and so were probably very inexperienced in making these calls. Hence the stress. So I wonder if now the people making these calls are more experienced in general.
Yeah, I think in terms of that, we'd have to see if there are still many physicians being redeployed due to COVID-19. I would think that specifically in New York City, probably not as many, just because of the lowering of our number of cases compared to peak, of course. But that would be something that I could look into.
Also, so it was interesting or depressing that training didn't help much, but that experience did. So, I guess that means we just need people who are experienced doing this for a while, and they'll be able to handle it better. And that training per se was not enough or didn't fix the problem.
Definitely, yeah, and also that there was this significant association between the first decision making and the physician's core values. I thought was very interesting, and that when we are counseling, physicians in terms of the mental health impact of COVID-19, to make sure that those core values are defined, I think is very important.
And I had one other just sort of technical thing. When you said triage, and we're not clear what it means exactly, is the main triage at admission versus not admission? Is that probably the major decision, or is it more often, putting them on a vent or something?
Yeah, absolutely. So that was one of the limitations in our study, because the survey didn't actually specify what kind of triage. And there are multiple types of triage, including within the ED itself, and when you're first receiving the patient into the emergency department, and also triage between deciding if the patient needs to go to the floor, and additionally, if the patient from the floor needs to go to the ICU. And so because those weren't defined, and the reason why that's important to define is because physicians do use different guidelines to inform patient management within those different steps of triage. And so I think that's why that was definitely a limitation in our study that would have been helpful if it was defined what kind of triage.